Hi all, welcome back to Emergency Medicine lecture series. In the current video, we are going to learn about the splinting techniques in the emergency department. Splinting techniques are one of the most important and commonly performed techniques either in the pre-hospital or in the emergency departments to stabilize the fractures and to transport patients safely either from pre-hospital to the hospital or within the hospital for radiological investigations before you can apply a slab or a cast. I'm Dr. Prakash Babu, Associate Professor of Emergency Medicine. Splints are used for temporary immobilization of joints. You all know that. They are used for fractures and dislocations. Sometimes they can be used for soft tissue injuries where you need to restrict the movement of a limb to allow healing of the soft tissue injuries like tendon injuries or sprains where ligaments are injured. The exact role of splinting for sprains, complications, and the number of days for healing are not known yet. Circumferential splints, also called as casts, have been abandoned because they won't allow the swelling to develop and they might cause compartment syndrome in the initial few days. So, pre-made commercial splints with plaster of Paris or fiberglass are preferred. Nowadays, there are aluminium splints which come with pre-padded and they can be molded to any shape. If a splint is properly applied, they provide short-term immobilization. For longer-term immobilization, you need to resort for circumferential casts. When you apply a pre-made commercial splints, they allow for space for continued swelling, minimizing risks of compartment syndrome and the ischemic injury. What are the indications for splinting in the ED? Any fracture or dislocation where you want to reduce the risk of damage by immobilizing the particular limb. To reduce injury to the neurovascular structures, you will be using splinting. For deep lacerations which cross the joints, to allow proper healing and avoiding wound gaping, you can use splints. For tendon lacerations, for inflammatory diseases like gout, tenosynovitis, where splinting temporarily reduces the pain and increases the recovery. For deep space infections of the hand or feet, wherein you need the fingers to be stabilized and not moving so as to give more comfort to the patient. If there is a cellulitis overlying a joint, you can use splints. In selected puncture or bite wounds, you can use splints. So what are the advantages of using splints? Immobilization facilitates healing process by decreasing pain. It protects the extremity from any further injury. Especially in fractures, they help maintain bony alignment and the bone fragments will not go and cause more damage to the soft tissues, especially the neurovascular bundle. Deep lacerations crossing joints, splinting reduces tension and prevents wound adhesions. In tendon lacerations, they relieve stress on the repaired tendon, hence promotes healing of the tendon. Inflammatory arthritis reduces pain and they give comfort. In patients with multiple trauma, it also is used to minimize the blood loss and potential for neurovascular injury. Splinting also reduces the need for opioid analgesia and the risk of fat emboli. So in short, these are the materials or the equipment needed for splinting. You need a stockinette, you need Webril or the gauge padding, you need plaster rolls, elastic bandages or the roller bandages, you need tape to secure the elastic wraps in place, you need scissors to cut either the plastic rolls or the Webril or the stockinette, and a bucket filled with water for preparing the plaster rolls. Equipment for free-formed fiberglass splints. You need a stockinette, elastic wraps, scissors, tape, free-formed fiberglass splint is required, and also the Webril is required. When you're talking about the equipment that are needed for splinting, you can divide them into the support materials, comfort giving materials, and accessory materials. Coming to the support materials, the most commonly used support material is the plaster of Paris, most widely used material in the ED for splinting. When added, water is added to the plaster, it recrystallizes into calcium sulfate dehydrate molecules. Plaster is impregnated into strips of rolls or creolin type material, which allows easy application of plasters. Creolin helps keep the plaster molded to a proper shape during the setting process and also adds support to the finished splint. Plaster rolls and sheets are available in a variety of setting times and widths. Plaster can be more easily molded and tailored to individual anatomy and are usually less expensive. Then you have prefabricated splint rolls. They have 10 to 20 layers of plaster sheets enclosed between a thick layer of protective foam padding. They're usually secured to the extremity with elastic bandages. They save time and are useful for intermittent splinting. They lack custom fit qualities. Prefabricated fiberglass splint rolls. They contain layers of fiberglass between polypropylene foam padding. They cure more rapidly without a messy residue. They're more expensive compared to your plaster of Paris rolls. Wood cast composite splinting material made of spruce tree chips and a biodegradable plastic usually comes as 1 to 4 mm thick slabs. It can be molded to shape on extremity by heating for approximately 20 minutes, and it takes 15 minutes for the wood cast to set in. They cause fewer skin reactions. Pad aluminum splints, which are commonly used in EDs in India and also in the pre-hospital setup. In the ambulances, the padded aluminum splints are used. They're compact, lightweight, and a versatile device. It is soft and also adaptable to the anatomy of the limb. They come in different varieties as long arm splint, short arm splint, long leg splint, short leg splint, and varieties. Usually used in emergency situations and also for the first aid purposes. They're made of ultra thin aluminum alloy and latex free closed cell foam. Come in different sizes and shapes for upper and the lower limbs. Protective materials. Stockinette is the most commonly used protective material. A single layer is usually used over the skin and under the cotton padding. It protects the skin, and when it is folded back over the edges, it gives a professional look and reduces friction, thus reducing the complications. Padding, usually cotton rolls are used. It protects skin and bony prominences and allows for the swelling to develop. Elastic bandages, they're usually used to secure the splint in place. They're secured in place with adhesive tapes, metal clips, or Velcro fix. And other materials you need are a utility knife, scalpel, plaster or trauma scissors, protective gear, and a bucket. The procedure for splint preparation and application. When you know which limb has been injured and which limb you are going to apply a splint, you need to measure the length of the plaster that is used to be used against the area to be splinted. Roll out appropriate layers of plaster, roughly 8 layers for upper extremities, 12 to 15 for the lower extremity, and place a single layer of stockinette over the extremity, and stockinette should extend 10 to 15 centimeters beyond both ends of the plaster ends. Generally use a 3-inch stockinette for arm and 4-inch stockinette for the leg. Wrap 2 to 3 layers of Webril or the cotton rolls around the entire area to be splinted, overlapping each pass by 25 to 50%. Whenever you are whenever you are rolling, each time you need to overlap at least 25 to 50% of the previous roll. Avoid any wrinkling in the Webril, which may cause pressure sores. Submerge the plaster strips in a bucket of water until bubbling stops. Do not use water hotter than 24 degrees centigrade. Using warmer water may cause thermal injuries because the plaster releases heat when it is activated. Moving on, you need to place the layers of your plaster over a table. Smoothen the plaster between your fingers and remove all excess water. Lay the plaster out on the table and smooth further to remove all the wrinkles and ensure uniform lamination of all the layers. Apply the plaster over the web brill. Smooth it over the extremity. Avoid using the fingertips, which may leave an indentation in the plaster. Layer of web brill may be placed over the plaster to prevent it from sticking to the elastic wrap. Fold the stockinette over the edge of the plaster and the web brill. This helps to hold the splint in place and provides a smooth padded edge. Secure the splint to the extremity with an elastic wrap by proceeding in a distal to proximal fashion. Do not wrap the elastic bandage too tightly, which may lead to, again, compartment syndrome and ischemic necrosis. If metal clips are used to secure the elastic wrap, cover them with a tape to prevent them from falling off. Alternatively, wrap can be simply secured with encircling tape. Place the extremity in the desired position and use the palms of your hands to mold the splint to the contour of the extremity. Again, avoid using your fingertips, which may leave indentations that result in pressure sores. If you are using a prefabricated fiberglass splint, almost the steps are similar. You need to measure the length of the splint to be used against the area to be splinted. The splints are usually available in variety of lengths and widths. Cut the splint to the length using a pair of trauma shears. Round the corners of the cut ends to avoid sharp edges of the fiberglass. Stretch the cotton padding several inches beyond the edge of the fiberglass on both ends of the splint to assure that there will be no fiberglass in contact with the skin. Prefabricated fiberglass splints require minimal wetting. Simply open one end of the pouch and run tap water over the fiberglass. When water exits the bottom, it is ready to apply. Excess water may wrung out. Apply the splint to the extremity if stockinette is used, optional though recommended. Fold the edges of the stockinette over the splint. This provides comfort and also holds the splint in place during application. Secure the splint to the extremity using elastic bandages wrapped in distal to the proximal fashion. For splints that involve the hand, cut a hole the center of the elastic bandage in the loop that is in the region of the thumb. Bring the thumb through the hole. This provides perfect fit and reduces branching of the elastic in the web space and allows for more thumb mobility. Place the extremity in the desired position and mold the splint with your palms to the contours of the body. Avoid using fingertips again. Again, the same thing. It can cause indentations and it can cause pressure sores. After the splint application is completed, observe for any vascular compromise. Whichever type of splint you are applying, once you apply a splint, you need to recheck for vascular integrity. Increase the patient discomfort. If either occur, you need to loosen the elastic strip. You should never discharge a patient with increasing pain after splint application. So that is about how you apply a fiberglass splint and also POP splint. So what are the caveats for proper ED splinting? Things you need to remember for a proper ED splinting are: always use cool, clean water. Do not oversaturate the plaster splint. Minimal water is required for fiberglass splints. Make the splint smooth when placing it on the patient to avoid bumps and pressure points. Smooth and mold the splint without squeezing it. Use the palms of hands, not the fingers, to mold the splint to fit the contour of the body part. Place the padded side against the skin. Extra cotton padding is optional, and optimally you can use an extra layer of cotton padding to allow for the swelling and also to give comfort to the patient. Simply roll the elastic bandage over the extremity without undue tension. Protect and pad the edges. Leave the fingertips exposed to check for circulation and sensation. Keep the patient still until the splint has dried down and hardened. Post-splint check includes function, arterial pulse, capillary refill, temperature of the skin, and sensation. Remember the mnemonic facts: function, arterial pulse, capillary refill, temperature of the skin, and intactness of the sensation, which gives you that the part is well vascularized. Emphasize and demonstrate splint elevation to the patient. Tape over the metal clips used to fasten the elastic bandage to keep them in place and avoid ingestion by children. So the areas of extremities where you need to use an extra padding include, if you take the upper extremity, olecranon, radial stridor, and ulnar stridor are all superficial and protruding bones where you need to use an extra layer of cotton padding. The lower extremities, upper portion of the inner aspect of thigh, patella, fibular head, Achilles tendon, medial and lateral malleoli need to be an extra layer of padding is needed. What are the complications of applying splint? Most common complications when you are applying POP splints are thermal injury as the plaster dries and releases heat from it. If you are using hot water or increase in number of layers of the POP, poor padding all increase the risk of burns. Whenever you have a complication of burns, remove and cool the splint and reapply the splint. Ischemia is one of the most dreaded complications, usually less compared to a cast. Tight application of Webril is the most common cause of ischemia. Instruction to ice and elevate the extremity will reduce the chances of ischemia. The other complications include pressure sores and infection. So we have been talking that splints are better than casts. So let us have a comparison how a splint is constructed, how a cast is constructed, what are the advantages and disadvantages. Splint, it's a non-circumferential. You apply only on the one side for support and you use layers of padding. Cast is usually circumferential, meaning it is applied surrounding a limb. Indications for splint application include acute and definitive treatment of selected fractures, soft tissue injuries like sprains and tendon injuries, acute management of injuries awaiting orthopedic intervention. The indications for casts include definitive management once the acute phase has been passed, simple, complex, unstable, potentially unstable fractures, you need to use a cast. Severe non-acute soft tissue injuries, unable to be managed with splinting, you can go for a cast. What are the advantages of splinting? As I already discussed, it allows for acute swelling, decrease the risk of complications, faster and easier application of splints, commercial splints available and appropriate for select injuries, may be static, preventing the motion, or dynamic, functional, assisting with controlled motion. Cast advantage is more effective immobilization. Disadvantages of splints: lack of compliance. Patient can easily remove a splint. So whenever he feels discomfort, he will remove the splint. Increase the range of motion at the injury site. In unstable fractures, it is not preferable. Not useful for definitive care of unstable and potentially unstable fractures. The disadvantage of cast, as we already discussed, it causes more ischemic injuries and high risk of complications. It is more technically difficult to apply when you need to place joints in specific positions when immobilizing. So let us look at some of the commonly used splints in different body parts. If you're using a hand or finger fractures, Usually you use an ulnar gutter, radial gutter, thumb spica, or finger splints. Forearm or wrist splints, volar splint or dorsal forearm splint, single sugar thumb splint can be applied. If there are injuries around the elbow and forearm, a long arm posterior splint or double sugar tongue splint can be applied. For knee, posterior knee splint, off the shelf immobilizer can be used. For tibia and fibula, posterior ankle, mid shaft and distal fractures, or bulky Jones splint can be applied. For ankle, posterior ankle or posterior mold, stirrup, bulky Jones, high top walking boot can be used. For injuries of the foot, a posterior ankle with or without toe box, hard sole shoe, high top walking boot can be used. Thank you. Don't forget to share and subscribe these videos to get it directly into your inbox. Thank you once again.